So the background for transcatheter tricuspid valve, either replacement or repair trial design, has to do with the guidelines and the gaps that are in these guidelines. So as you can see from this chart, we only have 2 Class 1 indications for taking patients to surgery at this time. The asymptomatic but severe patients who are at the time of left heart surgery, and the symptomatic severe tricuspid regurg patients at the time of left heart surgery. But in addition, we do have some Class 2A indications, and one of those is progressive functional, so that's a primary tricuspid regurgitation at the time of, secondary, at the time of left heart surgery with tricuspid annular dilatation. And then there's some specific cutoffs for that, which I'll review in just a second. And then also for primary disease over on this side of the chart, in the setting, again, of severe symptoms. But again, only 2 Class 1 indications, and both of those are at the time of left heart surgery. So only 2 Class 2A or B indications for isolated tricuspid valve repair or replacement. And the level of evidence is terrible. This is really an understudied valve. And as you can see, the one indication with tricuspid annular dilatation in the absence of severe regurgitation is an annular size from a 4-chamber view of greater than 40 millimeters or 21 millimeters per meter squared, so index to body size. And Joao already showed beautifully why this is I'm going to use a relatively strong word, but a nonsensical measure, because it all depends on the angle at which you obtain that 4-chamber view. And so these guidelines really need a lot of work, and so we're designing trials now in the absence of understanding and knowledge, which makes this talk really difficult. So the issues with the tricuspid regurg is obviously to distinguish primary versus secondary disease. There are significant differences in presentation and pathophysiology, and then the grading of severity, because it's only severe disease that at this time we have indications for taking to surgery. And so when you look at the guidelines which separate the diseases out into stages A, B, C, and D, the severe symptomatic patients, you must first obviously determine the morphology, and this is the same for mitral as well. But then what they've written in the guidelines is to quantify valve hemodynamics and severity of disease using a jet area of a single vena contracta with jet density and contour and hepatic vein flow reversal, which is what I'm going to concentrate on first. And then we'll talk about the hemodynamic consequences and the fact that the symptoms are so vague at fatigue, palpitations, dyspnea, bloating, and anorexia and edema. So when you talk about using jet area, and I'm hoping the guidelines will change, the problem really is that we have all of these different measures of severity of regurgitation for tricuspid valve, but they have a lot of limitations. The tricuspid regurg jet, it turns out, is typically all along that septal commissure, which means that it's going to be crescent-shaped in a huge percentage of the time. And that means that any single measure of a width can be very, very misleading. So either you'll get that big width and then you'll think it's absolutely torrential, or you'll see that narrow width and you'll think, oh, it's only mild disease. In addition, jet area, it turns out, and then all of these other things are obviously just qualitative measures. Reversal of flow is a fairly specific sign, but remember, reversal of flow in any other vessel is dependent on the compliance of the 2 chambers that it's involving. So the right atrial compliance and then also what's happening with the IVC. But in any case, when you're using jet area, the main problem is that jet area is determined by momentum. So when you think about the pressures on the left side of the chest versus on the left side of the heart versus the right side of the heart, then the high pressures on the left side of the heart are going to create bigger jet areas for the same severity of regurgitant orifice than on the right side of the heart. And the 10 centimeters squared that we are using for the right side is the same that we're using for the left side. So now we've taken what really is torrential disease on the tricuspid side and we're calling it severe. And this is one of the major problems now with tricuspid regurgitant disease and the field in general, which is that we're getting to these patients way too late. Clinicians thus rely on jet areas, since the guidelines tell us to do so, which we'd like to move away from. And then quantitation relies on proximal isovelocity surface area, so a single linear measurement of the radius of the proximal flow. Again, in a time-varying jet, not really a smart idea. So this is really a work in progress as far as I'm concerned, and that because of that, there are other surrogates of severity that have been used. Tricuspid annular dilatation and leaflet tethering, Joel spoke about, thankfully, and it has to do with the anatomy that Doug spoke about. So you know that the septal leaflet has multiple chordal attachments to the septum. There's almost an innumerable number of papillary muscles or direct chordal attachments of that leaflet. Consequently, and in addition, there's one big papillary muscle, the anterior papillary muscle, and then a second papillary, the posterior papillary muscle, tends to be smaller. And that anterior papillary muscle is attached to the lateral wall of the RV. So as you get dilatation out from the RV, or you start to see movement of the septum toward the LV, all of those things are going to tether up the leaflets and result in significant malcoaptation of the valve and regurgitation. Consequently, annulus size and tenting of the valve have been surrogates of severity of regurgitation, but also predict recurrence after tricuspid valve repair, so after surgical repair. So we know that it's not just about the annulus, it's now about the leaflet tethering and the right ventricle. Obviously tenting volume a little bit harder to determine. It's done on three-dimensional echo. So the importance of annular dilatation and the reason why it got into the guidelines is that there are numerous papers out there showing that annular dilatation is bad, and that annuloplasty, this is the infamous paper by Giles-Dreyfus, annuloplasty based on annular dilatation associated with an improved functional status prevents progression. Annuloplasty for moderate TR, so that should be TR, at the time of left heart surgery associated with left TR follow-up. Annuloplasty for less than moderate TR at the time of left heart surgery associated with reduced progression, improved remodeling, and better functional outcomes. All in all, this beautiful review by Joanna Chikwe showing again that in the setting of concomitant disease on the left side, that one should be thinking about annular repair, annuloplasty, to arrest TR progression, since it is durable, and I have a real problem with that word, durable, because multiple studies have shown that it recurs after 5 years, causes reverse RV remodeling, that's fairly strong evidence, clinical improvement, again, fairly strong evidence, and trends to survival benefit, that's the kicker. No surgical study has shown a survival benefit with a tricuspid annular repair. So the third issue with tricuspid regurg is the pathophysiology of the disease. It's a volume overloaded state, which is really well tolerated for years. Pressure is not that well tolerated. Remember, the RV is thin-walled. As Doug told us, it's very, very different. It's kind of lopped onto the side of the left heart, and pressure is not tolerated well, but volume overload is tolerated well. We frequently will see no reduction in RV function for a long period of time, partly because we have limited ability to judge RV function. We're getting better and better with strain imaging and other measures with on CMR, and then few symptoms of insidious onset. So these patients complain of a little of edema, they're a little bloated, they're fatigued, they just don't feel right. And unfortunately, because this is a disease of the elderly, as so many valvular diseases are, many of those symptoms are attributed to aging. There's no prior interventional therapy available except surgical tricuspid valve repair or replacement, and the only guideline-directed medical therapy is a diuretic. A class 2 guideline therapy is treatment of pulmonary hypertension. Poor understanding about grading of severity, we've already gone over. Color jet is also sensitive to loading conditions. So one day you can have torrential, and the next day you can have mild. It's the same thing that happens with interventions. On the table, you think you've done a perfect repair, and then they wake up, their hemodynamics change, and all of a sudden that repair is not so good. Just out of the box, when you look at surgical repair results for how much tricuspid regurg is left on transthoracic echo immediately after surgery, 30% of them don't have a good result. And so this is a very sensitive jet, sensitive to loading conditions. And then dilatation of the right atrium results in underestimation of severity by jet area, since we know, and these patients present very, very late. In fact, this hemodynamic consequence that we normally look at for left-sided disease, so we use left atrial dilatation as a surrogate for severity. It's very, very difficult to know what comes first in tricuspid regurg, the chicken or the egg. Is it that the right heart dilates and then you get tricuspid regurg? The right heart is dysfunctional and then you get tricuspid regurg? Or is the tricuspid regurg the actual culprit? And the problem is it's probably a little bit of both, but we know now that atrial and ventricular size actually will predict severity as well. And so it may be that tricuspid regurgitation is a consequence of all these other problems like pulmonary hypertension and right ventricular dilatation. But this indeed is the type of patient that we see. This is effective regurgitant orifice area of over 2 centimeters squared. This is humongous, but these patients are walking around and they're probably in everybody's practice in this room. And so we proposed to increase the grading scale, since we underestimate severity of regurgitation by color jet, to include massive and torrential, and frankly, we've seen torrential times 3 coming to our interventions. So this is severe, massive, torrential. You would normally have called this maybe moderate, maybe even mild to moderate, but this quantified to severe, and this is obviously massive, and you can see the torrential nature with massive dilatation of the right atrium on the last slide. And so Maurizio Taramasso has proposed different phases of tricuspid regurgitation, with phase 1 being initial right ventricular dilatation with an annular dilatation without much tricuspid regurgitation, but then as the disease progresses with more dilatation and more right heart dysfunction and tricuspid annular dilatation, you get more regurg. And then finally you get the failure where the RV is massively dilated, the TR is now torrential, there's pulmonary hypertension that may be involved. And although this looks like a progression, there are some patients that don't have this same progression, and I think we're learning about those patients now. But the bottom line is, this is just an example from the surgical literature. When you look at those patients who come for surgery, the determinants of mortality are not only age and gender and New York Heart Association class, but liver cirrhosis, anemia, poor nutritional status, and renal dysfunction. All of these things tell us the type of surgery didn't matter. So there's a lot of studies out there that say repair has a better in-house outcome compared to surgery. Well, it turns out that, to compare to replacement, but it turns out that the replacement patients all have more advanced disease. And so when you normalize for that, there is no difference in outcomes between whether or not you repair or replace. But the thing that really determines outcomes is how much comorbidity they have. And so we operate too late on these patients, as you've seen. So now on to the bulk of the talk. There's just a couple of slides here because we really don't know yet what we're going to do. But when we look at the TR feasibility, early feasibility studies in the US, these are very small studies. Sometimes they require extension, as we've done with the SCOUT trial, and Chris is going to talk about that. They're observational, so we're not randomizing to anything. They're not really powered at all for outcomes of any kind. And they emphasize the delivery of the device and technical success, and then careful clinical follow-up with rigorous imaging analysis. With inclusion criteria is obviously what seems obvious: moderate or severe symptoms, severe or sometimes moderate TR, primary or secondary, depending on the type of device, and then the exclusion criteria, plus minus extreme or torrential TR. The FORMA trial allowed, and I think we'll have a talk on FORMA, the FORMA trial allowed absolutely torrential. There was a patient there with 4 centimeters squared in that early trial. And then severe RV dysfunction and failure typically excluded severe pulmonary hypertension with a random number of 60 millimeters of mercury, typically excluded, and then cirrhosis, end-stage renal disease also excluded. And their outcomes were mainly for safety. So all of these early feasibility trials are safety studies. And when we look at effectiveness, again, they're not really powered to show these, but many echo measures of effectiveness, as well as some biomarkers, and I can tell you now that left-sided biomarkers aren't going to work for the right heart. And then clinical outcomes are mainly based on functional endpoints, so 6-minute walk, quality of life assessment, diuretic responsiveness, edema scales and indices, edema questionnaires, et cetera. And so when we go to design our pivotal trials, we're looking at, again, a complex risk-benefit determination, which the FDA is very good at. We're looking at the stability of the technology before we take it to pivotal trial. We're looking for trial designs to help achieve a new standard of care. And so consequently, that standard of care is dependent upon those guidelines, which obviously are significantly lacking. And so again, a relatively low bar for the tricuspid regurgitation trials. And the ultimate goal is to achieve a transcatheter approach that reduces complications of open heart surgery and provide a durable TR reduction associated with improved clinical outcomes. And so this is that now famous risk-benefit determination, John Lasseter obviously with the FDA, that shows us how we make these decisions of balancing risk and benefit. If it's an extraordinarily low-risk procedure with no mortality, then we're much more likely to adopt it, even if efficacy is not as good, versus a higher risk procedure, which may be more efficacious, but has more complications associated with it. So again, it's a risk-benefit analysis for every device that comes to trial, and the tricuspid is going to end up being somewhere in there. It's never going to, because we don't believe we have, it would take a long and very large trial to show mortality benefit. We may be living in the relatively low risk and relatively low efficacy, but low risk arena for the tricuspid valve. So again, pivotal trial design, we're looking at the same effectiveness by echo, although we are learning more about RV function and remodeling. We're looking at biomarkers and trying to figure out what biomarkers might be effective for liver function and renal function. And then in addition to the functional endpoints, we would love to have hard outpoints, which may not include death, but may include combinations of and composites of death, rehospitalization, and freedom from repeat procedures. So in sum, timing of intervention is difficult because we don't understand severe TR. We don't know how to grade it yet, but we're working on it. There are surrogates of severe TR which seem fairly robust and make a lot of pathophysiologic sense. And then there are symptoms, and then the guideline-directed medical therapy is limited. And so that really opens the door for these transcatheter procedures. And then the endpoints that we'll be looking at is not only efficacy from TR reduction and other echo parameters of RV remodeling, but hard endpoints and functional endpoints. Thanks for your attention.
As Richard is setting up here, I have a question for you, Becky and Chris and the panel. I think one of the challenges here is that a lot of the transcatheter therapy these days are being proposed as surgical alternatives. If you look at the path of TAVR, it's a surgical replacement. Mitral, maybe, but TR, I'm not so sure. As you astutely pointed out, there are no class 1 indications for surgery in these patients. So the way I look at it is that it's more of an adjunctive to medical therapy. And the trials, I think, probably should try to reflect that. They're still being designed. I know we're on the steering committee together for TrueLuminate, and I think we have to discuss these endpoints. But I think there's a huge challenge out there to redescribing what the transcatheter therapy should be. Just curious on what your thoughts and those perspectives would be.
I 100% agree with you. I mean, I think because, again, we don't have the strong outcomes data from surgery, and it's very hard for us, if you isolated tricuspid valve surgery is associated with an 8.8% mortality, in-house mortality. It's it's a pretty low bar for us, I think, with
And
transcatheter
and
devices.
It's 13% if you're replacing. so every tricuspid surgery is high risk. So it's almost like it doesn't matter. It's not really, we're not really trying to replace a high risk procedure.
Yeah.
I think we're more trying to determine, well, what role would this have in an average patient who's being managed with diuretics currently? Because I don't ever see a randomization against surgery in the works. I just
hope
don't
not.
think that's going to happen.
I hope not, because
Yeah.
you are then committing a clinician to giving their patient either a new device or a 10% chance of dying.
Exactly.
And I just don't think anyone can live with that. So we will never randomize, I don't believe we should.
Right.
We should never randomize to surgery. This should only be randomized against guideline-directed medical therapy.
Yeah, so then it becomes a medical therapy trial.
Yeah.
And we have to avoid falling in into the co-op trap, and making things very difficult to enroll and randomize. But I do see it that way, and hopefully we can take the surgical risk discussions out of this.
I think those are great points, Paul. I mean, the challenge is the one part that'll make it a lot easier than co-op from a medical management is it's just diuretics. It gets a little easier, but there is a lot of art to that too. And I mean, switching patients to torsemide from Lasix, are they really diuresis or not? I mean, it's hard to assess in a lot of these patients. Just the endpoints are going to be so challenging, as we've seen, with TriLine we'll talk about it in a bit, but a lot of these devices, they all leave a reasonable amount of TR no matter what you do, but these patients feel a lot better. And now we've got to probably base a trial on how much better patients feel, which there's a lot of challenges in trying to have a trial that's the hard endpoints in it. And then on top of it, if that's your endpoint, then getting the buy-in from our cardiology colleagues across the spectrum to say, okay, well, you did this to this patient, they still got a reasonable amount of TR. I know you think they feel better, but am I really going to start sending my patients like it is for TAVR or for MR, where you really see these differences? I think it adds so many layers of complexity to seeing these devices move forward as quick as we've seen in the other spaces.
I mean, I guess we have a little time here. I mean, what moderate TR is often the current entry criterion for triluminate, but we're trying to get patients to decrease by 1 grade, so they may only go from torrential to severe. So how do we reconcile that the entry criteria is less in terms of severity than the eventual goal? So in other words, you're enrolling moderate patients, but we're accepting that it's only 1 grade reduction, which may be severe or massive. How do we reconcile that?
Can I add one layer of complexity to that problem? My biggest challenge is you're exactly right with that, but the problem is it may be moderate yesterday, and then without doing a single different thing, a day later it's like torrential. I mean, almost. I mean, that's the hardest thing to sing. It is insane how much I'm going to show a patient that we had this thing with, where you could the variability with small changes in volume status, work pressure management, it's incredible. And what that does is it just complicates the actual regurgitant, how much regurgitation we actually have in measuring that. And that's where all these other parameters we need to really find that become relevant instead, because I don't know what to make of half that data. We have these TR cases where TR is gone at the end of the case, we're Chi-5 and all that stuff. The next day their TR does not look so hot that, on TTE. They come back in 30 days and they feel like $1 million. And I'm looking at their echo, I'm like, are you sure? And so it's
usually when I have Richard turn the echo off.
And we tried it. We've been working on that. That's the real plan. Yeah, stop looking. Yes, exactly.
Thanks, right?
Exactly.
Yeah, no, I think that's exactly right. It's such a hemodynamically variable jet, but the effective regurgitant orifice area may not be as variable, and so we're trying to come up with ways, and it may end up being, using multiple modalities to confirm the regurgitant orifice area or the anatomic regurgitant orifice area, but also, as Chris says, to look at the other. We should see RV remodeling. We should see an increase in forward flow. We should see improvement in liver function or renal function.
I think, you're absolutely right. The reliance on CollaJet and many other things, for me, it's very clear that it's the forgotten valve, not for a reason. It's because it's missed. It flies under the radar screen, and, it goes by so many years, and we go back and said, it was severe back 2-3 years ago. What are they talking about then? So it's undercalled, it's underreported, it's incredibly variable. So I think we need more specific clinical combined with some anatomical. It has to be multifactorial. Now the question is, if they feel so much better, we do the interventions and we still see sometimes a lot of TR. Should we consider sham procedure?
Well, that's.
Some would consider it.
So I think it's either a sham or you have to have some imaging to document why the patients feel better. I don't think it can be just 6-minute walk and KCCQ. And so there are some who are actually pushing for RV volumes and MRI as being the hard endpoint, or at least one of the hard endpoints, kind of like the CTSN study that used LV end-systolic volume indexed for secondary MR. I don't know if we're ready to do that, and I don't know if there are enough centers that have expertise like Joao and others to do such advanced imaging. At the very least, there should be a sub-study, I think, to support the clinical trial endpoint.